Oh, hello, everyone. My name is Damon Scales from the University of Toronto in Toronto, Canada. I'd like to start by thanking the organizers for inviting me to speak at this conference. My topic is balancing the risks of clot versus bleeding after traumatic brain injury. This is a very common problem that we encounter frequently when managing these patients, but surprisingly is little known about how to balance these two opposing risks. I do have a conflict of interest to declare. I hold an operating grant from the Canadian Research Organization, Canadian Institute for Health Research, to study this topic, and I have no other conflicts to declare. I'm going to start by discussing an illustrative case. Hopefully this will be a common scenario that will resonate with you. A 25-year-old man who's admitted to our intensive care unit after an isolated traumatic brain injury following a fall from height. His initial Glasgow Coma score is 5, and he has no significant past medical history. You can see from his initial CT scan, there's a skull fracture and a large intracerebral contusion. He undergoes an urgent craniotomy, comes back to our intensive care unit. We start him on our severe traumatic brain injury protocol with usual supportive care. And his examination off sedation following the procedure shows that he has a Glasgow, a GCS now of 6T. He withdraws to pain, no eye opening, and of course he's intubated. This is his repeat CT scan. You can see that he's had an effective decompression. There's been an insertion of an external ventricular device. And we go about our usual practice of providing supportive care following his traumatic brain injury in our intensive care unit. And a frequently posed question on our rounds is, what is his risks of DVT or PE? And similarly, what is his risk of having intracerebral hemorrhage progression? Well, we do know that this population, traumatic brain injury, is one of the highest risk populations in terms of the frequency of venous thromboembolism. VTE is very common in this population, not surprisingly, because they're often immobilized for an extended period of time, receiving sedation, paralytics, etc. But also the underlying neurological lesion may actually lead to a prothrombotic state, leading them to be at even higher risk. The estimated incidence of DVT in this population is very high, with very wide ranges reported in the literature, between 10 and 50%. And a wide range like that should be frustrating to all of us. It doesn't seem very precise, but it reflects the differences in different studies in terms of the patient population, the severity of brain injury, and perhaps most importantly, the degree with which the researchers actually looked for DVT systematically. Certainly in other patient populations, we would simply start anticoagulant prophylaxis upon admission to the intensive care unit as the preferred strategy to reduce venous thromboembolism risk. However, in this patient population, of course, there's a lot of anxiety that any anticoagulation might increase the risk of intracranial hemorrhage. And even low-dose heparin or low molecular weight heparin are often considered to be contraindicated, especially in the early period. We've sort of solved this problem for elective neurosurgery, and there's been several randomized controlled trials. I show one here that was published in the New England Journal of Medicine that illustrated it. It really is quite safe to start anticoagulant prophylaxis on the day following surgery, with striking effect. In this study, you can see that the rate of DVT or PE was cut in half by the use of anticoagulant prophylaxis postoperatively. Surprisingly high rates in this elective neurosurgical population, but I'd highlight that in this study, they actually actively screened all patients for DVT, likely detecting many DVTs that would have otherwise gone clinically undetected. They did not find any evidence of harm or increased rates of bleeding in this study. What do we know about the risk of intracranial hemorrhage progression after TBI? Well, similarly, very wide ranges in terms of the risk reported in the literature, rates of hematoma growth ranging from 0 in some studies to 45% in others. Certainly the risk in observational studies does seem to be slightly higher with anticoagulant prophylaxis, although that signal is not entirely consistent. And if the intracranial hemorrhage is going to occur after TBI, it most often occurs in the first 24 hours after the injury. This is a very nice systematic review that was published recently that tried to get a better handle on the actual risk of intracranial hemorrhage progression. The authors found 21 studies, only 2 small randomized control trials. And in 18 of these studies, they were able to determine that actually starting anticoagulant prophylaxis after a stable head CT did not lead to TBI progression or intracranial hemorrhage progression. In 14 of the studies, there was enough information for these investigators to deem that starting anticoagulants were likely safe within 1 to 3 days after a stable injury. And 4 of the studies that actually measured systematic intracranial hemorrhage progression didn't find any within the first 24 hours. Lots of caveats and limitations, however, to this systematic review. Predominantly observational studies, which of course make them highly vulnerable to treatment indication bias. Fundamentally, in most of these studies, there's a physician standing at the bedside making the determination about the safety of starting anticoagulant prophylaxis. Lots of heterogeneity across the studies in terms of the severity of TBI. And on that point, most of these studies only included low-risk traumatic brain injury, and most patients with high hemorrhagic risk were excluded. Finally, a lack of standardized screening for the risk of both ICH, intracranial hemorrhage, or venous thromboembolism. The authors of this systematic review felt that there was enough information to provide guidance for the low-risk traumatic brain injury population, and this algorithm is very similar to what we use in our hospital. In a low-risk patient, we'll typically start anticoagulant prophylaxis after we see that a repeat CT scan on 24 to 48 hours is stable. But fundamentally, this algorithm excludes patients with severe traumatic brain injury, similar to the patient we discussed at the start of the talk. Perhaps modeling science can help. We attempted this to try to use decision analysis using the available evidence in terms of risks and benefits of early anticoagulant prophylaxis. And to make a long story short, the study concluded that this is really a toss-up. There was insufficient data to actually inform the decision, but we did establish a few thresholds. If we believe that low molecular weight heparin is effective at preventing DVT in the range of relative risk reductions between 33 and 82%, then actually it's the favored strategy. And if it only increases your risk of intracranial hemorrhage more than 5% above the baseline risk, it's also the favored strategy. The challenge here is that I think that those ranges are very much within the plausible range of risk and benefit, so not that helpful. Well, maybe we can just learn by looking at what people are actually doing in practice. This is a survey of Canadian neurosurgeons and neurointensivists that was conducted a few years ago on this topic. When we asked neurosurgeons and neurointensivists if they would ever prescribe anticoagulant prophylaxis, between 75 and 88% of the respondents said they would ever start it. You can see not much difference in terms of practice patterns reported for intensivists or neurosurgeons. And you can also see that when we asked them when they would start it, by about 7 days, among the respondents who would ever start anticoagulant prophylaxis, most were comfortable in that time frame. Not surprisingly, in a scenario where we described a patient similar to the one we started at the beginning of the presentation, a patient with severe traumatic brain injury, only 60% of the respondents said they would ever start anticoagulant prophylaxis. But again, among those who said they would ever start anticoagulant prophylaxis, the time reported in terms of when they would start it ranged from 3 to 4 days, and by 7 days, most people were comfortable. Just to reassure you, this isn't a Canadian practice pattern. Very similar survey conducted in the UK with almost identical findings, showing that in a cases of severe traumatic brain injury, where the risk of intracranial hemorrhage is arguably higher, most physicians that would start anticoagulant prophylaxis wouldn't do so until between 4 and 7 days after the injury. A nice observational study conducted using the Trauma Quality Improvement Program database from the United States, and a very large number of patients. Again, this is reflects actual practice, not reported practice. Very similar, though. About 40% of patients in this cohort had not received any anticoagulant prophylaxis more than 5 days beyond the injury. These were patients with severe traumatic brain injury defined as a GCS less than or equal to 8 at presentation. And among the patients who did receive anticoagulant prophylaxis, the median time to initiating it was about 3.5 days, and by 7 days, most of the patients that did receive anticoagulant prophylaxis were receiving it. Certainly in this study, there's also a signal showing that anticoagulant prophylaxis is effective at reducing the risk of pulmonary embolism and deep vein thrombosis, with a reduction in the rate seen when the anticoagulant prophylaxis was started early compared to late, and really no signal from this observational study showing that earlier anticoagulant prophylaxis led to a risk of higher rates of intracranial hemorrhage. Again, the caveat being that there's limitations by indication bias. What about intermittent pneumatic compression devices? Well, the best evidence for these has to be taken from studies in stroke patients. This is a very nice study, the CLOTS-3 study. No traumatic brain injury patients, but everyone had a stroke. Only 13% of these were hemorrhagic. And certainly, using intermittent pneumatic compression devices decreased the risk of developing venous thromboembolism. No attempt in this study to measure systematically rates of intracranial hemorrhage progression. And it's a hard study to extrapolate to this scenario because 1/3 of the patients were receiving prophylactic or treatment dose anticoagulant. What do the guidelines say? These are very nice guidelines published by the Neurocritical Care Society. They strongly recommend using intermittent pneumatic compression devices, again, highlighting that the evidence for this is extrapolated from the stroke population, and they highlight this is a weak, so I said a strong recommendation. It's actually a weak recommendation based on low quality evidence. And they do recommend initiating anticoagulant prophylaxis, but waiting for more than 24 hours after a craniotomy, and again, a weak recommendation and low quality evidence. The third bullet to me is the same as the first one. Again, they seem to like intermittent pneumatic compression devices. The Brain Trauma Foundation has slightly more conservative recommendations, saying there's insufficient evidence to support using anticoagulant prophylaxis. The product monograph, just to highlight, actually recommends against using anticoagulant prophylaxis in these patients, cautioning that cerebral hemorrhage and injuries to the central nervous system are absolute contraindications. So really that means every time we start these medications, we're using them off-label. We're planning a large randomized control trial on this topic. It's already underway. We'll recruit patients with severe TBI, and it will establish the effectiveness and safety of a strategy that provides early, within 48 hours, anticoagulant prophylaxis compared to delayed 7 days thromboprophylaxis. And this is running across Canada. To summarize, our study will address a common clinical dilemma, evaluating the risks and benefits, and will be the largest ever conducted on this topic. But until we have the results of more randomized trials, these are my recommendations. For mild to moderate TBI, start after a stable CT, 24 to 72 hours. Severe TBI, if you have intermittent pneumatic compression devices, you should use these. And if you don't have them, consider starting anticoagulant prophylaxis 3 to 4 days after TBI, but only if the CT scan is stable. Thank you for listening to my talk, and enjoy the rest of the conference.